Следующая презентация профессора Poortmansa из Тилбурга, Нидерланды. Два слова о профессоре Poortmanсе. Он известный радиационный онколог в Европе. Годы участвовал во многих исследованиях Европейской ассоциации исследования лечения рака и РТС, является членом наиболее серьезных исследований, которые сейчас стали уже классическими. Он является сегодня президентом Европейской ассоциации радиационных онкологов, ЭСТРО, и давним нашим другом. Please, Professor Bogomolca.
Thank you very much for the introduction, although I don't understand it truly, but I can estimate or guess what you told. Good morning, everybody. It's a pleasure for being here. It's my first time in Ukraine. I've been in several other states around Ukraine, but the first time in Ukraine. And I was last week indeed a little bit worried on what happens, because the reflection of the news you get is not always as correct as what's really happening on site. Now, I'm very happy that I can share with you some data, but also some thoughts. It's not all about exact science, it's also the interpretation of the data, because data can be interpreted in different ways. For example, the primary systemic approach, called neoadjuvant, but we will take care that this word will not be used anymore in a couple of years. So the primary systemic or preoperative systemic approach is a very attractive one, and I come back to that in one of my presentations. Now, let's start with radiation therapy of breast cancer. General, what about methods, and some news. Just this, I think. Yes. So I have no conflicts of interest. Now, what is the relation between local regional control and survival? Is there a relation? Now, we know it for a couple of years. This is an older presentation. It's published in 2005 by the Early Breast Cancer Trialist Collaborative Group, the EBCTCG, based in Oxford, and they combine all trials, prospective trials published in breast cancer, and then they evaluate the influence of hormonal treatment, of chemotherapy, of surgery, of radiation therapy. And this publication, 2006, was a very important one, because it showed for the first time in a very clear, unambiguous manner what the relation between local control, and this is, by the way, local regional control, so the breast and the lymph nodes at 5 years, was with survival at 15 years. So breast cancer mortality at 15 years related to the reduction in local regional recurrence rate at 5 years. And you can see that when the local recurrence rate is decreased by radiation therapy with less than 10%, the influence on overall survival is very low. It's neglectable. But when the reduction in local regional recurrence rate at 5 years is 10 to 20 or even more than 20%, there is a clear benefit in overall survival at 15 years. So we need to reduce local regional recurrences by at least 10%. At least that was what we thought 8 years ago. And the relation is about 1 to 4. So for every 4 local regional recurrences avoided, 1 death will be avoided at longer term follow-up. And this was questioned from the early start, and even the people from the EBCTCG were not so happy, but they could not state otherwise, because this came out of the data. Now, if you then look to 2 important groups of patients, that are patients with breast conserving therapy without nodal involvement of the axilla, and patients after mastectomy with nodal involvement of the axilla. I think this is the majority of the patients. You can see that the benefit in both groups always exceeds the 10%. So if you go to breast conserving therapy, or you go to post-mastectomy with axillary lymph node involvements, radiation therapy will always have a benefit exceeding 10% and thereby possibly having a benefit on overall survival at 15 years as well. Now, the proof of the pudding is in the eating, so there is a very important set of trials, in fact the Danish trials which were done in the 80s. You can have a lot of discussion about the systemic therapy used, but anyway, it were more than 3,000 patients. The patients who were premenopausal received chemotherapy, and the patients who were postmenopausal received tamoxifen. All patients had mastectomy, and half of them had no radiotherapy, and the other half had radiotherapy. And they divided the more than 3,000 patients in 3 subgroups. And the 3 subgroups was the favorable subgroup. They had up to 3 nodes involved, a smaller tumor, ER positive, HER2 negative, grade 1. And if 4 out of the 5 criteria were met, it was favorable. The unfavorable patients had at least 2 out of 3 criteria, more nodes involved, a big tumor, and grade 3, and the intermediate risk group was everybody in between. Now, in the patients who had no radiotherapy, it was very clear that the division into risk groups works. The local regional recurrence rate at 5 years was 11, 26, and 50% for the good, intermediate, and poor prognosis group. Now, for local regional recurrences, radiation therapy decreased significantly at 5 years the rate from 11 to 0% for the good, from 26 to 5% for the intermediate, and from 50 to 14% for the poor. This is local regional recurrence. If we then go to disease-specific survival, there was a clear benefit for the good prognostic patients, an intermediate for the intermediate risk patients, and nearly no benefit for the poor risk patients. And if you then go to overall survival, you see that this is about the same, but of course, because of that, due to other reasons, a little bit lower. And then, combining all of this, the low, intermediate, high-risk group patients without and with radiation therapy, local regional recurrences, disease-specific survival, overall survival, you can see that in the low-risk group patients, the patients who have a low risk for not only local recurrences, but also low risk for distant metastasis, you see that reducing, avoiding a local recurrence will clearly benefit on overall survival. While in the intermediate risk, it's not completely translated, of course, because of the risk of distant metastasis. And in the high-risk group, a clear benefit on local regional control was seen, but this not translate into an overall survival benefit because all those patients had distant metastasis at long-term follow-up. And this is then, of course, the explanation that patients are treated in the 80s with much less effective systemic therapy. Now, the 1 out of 4 was true for all patients together, but it is nearly 1 out of 10 in the high-risk group, 1 out of 2 in the intermediate, and 1 out of 1 in the low. And in the later presentation, I come back to that. So it seems quite obvious, but it was not interpreted as such anyway. Then, this was the mastectomy. We go to breast-conserving therapy. Now, do we need radiation therapy after a lumpectomy? And there are some data also from the EBCTCG. This is more recent. This is from 2011. In more than 7,000 patients without axillary node involvement, you can see that the benefit of radiation therapy on any recurrence, EBC-TCG clearly changed their approach, and they're still looking, but they're not anymore focusing on local regional recurrences alone. They're looking on any recurrence. That means also metastatic disease. So in those patients, radiation therapy decreased by 50% the risk of any recurrence at 10 years, and this led to a benefit in breast cancer related mortality at 15 years, again about 1 out of 4. In patients who had node positive disease, also breast conserving therapy, the any recurrence was decreased by about 1/3, a benefit of 21%, and the breast cancer mortality was decreased by 8.5%. Here we start deviating from the 1 out of 4 rule. So breast conserving therapy, it's clear for nearly all patients we need radiation therapy, and we're used to give, at least in Western Europe, we are used to give a boost to the primary tumor bed. Now, in the end of the 80s or in the 90s, we did a trial, the ERTC Boost No Boost trial, in which patients after lumpectomy all had whole breast irradiation, and then half of them received a boost, a higher dose to the primary tumor bed. Endpoints, local control and cosmesis, and the results are very clear. Only one difference, that is that the local recurrence rate decreased by nearly 50% by adding a higher dose to the primary tumor bed. All the other endpoints, distant metastasis, death due to breast cancer, death to other causes, did not change at all. We had, based on this, we designed a nomogram. Nomograms are very popular. I often wonder how often they are used in clinical practice. But this anyway is a nomogram which is available online to estimate the 10-year proportion ipsilateral breast recurrence-free survival. For example, you have a patient with a tumor of 2 centimeters, the age is 65, she did receive tamoxifen, no chemotherapy, she had no DCIS and a low or an intermediate grade primary tumor. If this patient receives no boost, her risk at 10 years for a local recurrence is 3%, and if she receives a boost, it's 1.5%. That's not a lot. But if you take another patient with higher risk, 3 centimeters, younger, 40 years, no tamoxifen, yes chemotherapy, yes DCIS and a high grade, then without a boost you have more than 20, about 25% local recurrences, and with the boost it decreases to 12%. So you can use it, but the question is this still true? And I come back to it in one of my later presentations. And the boost has a disadvantage, because due to the boost we see a less favorable cosmetic outcome. Without the boost, the cosmesis after treatment was excellent to good in 86% of the patients, and with the boost, this decreased by 15% to 71%. And this can be explained by fibrosis. We had in fact 4 dose levels in the trial. This is without a boost, this is with a low boost, this is with a standard boost, and with a high boost. And you can clearly see that the higher the dose to the primary tumor bed, the higher the risk that the patient will develop fibrosis, which is scar tissue formation at the primary tumor site or elsewhere in the breast. And also this can be estimated using a nomogram. So a patient of 55 years of age, and the patient had no hematoma or edema. The patient was postmenopausal, received tamoxifen. Tamoxifen increases the risk for fibrosis. no concomitant chemotherapy, standard radiation therapy, a boost with electrons, and the maximal dose was this. So she had at the end 127 points, and 127 points means that this patient had a 27% risk of developing moderate to severe fibrosis. So based on this nomogram we can estimate it as well. Both are combined and available, free available on the internet, where you can estimate the ipsilateral breast recurrence rate as well as the risk for fibrosis, and you can discuss it with your patients. The next step is, do we need to treat the entire breast? So accelerated partial breast irradiation. Now, why would we want to do this? And do we want to it for the right reasons? Now, this is a publication from the United States in 2000. The distance that the patient is living from the nearest by radiation therapy department. 25 kilometers, 300 kilometers. And you see that the rate of breast conserving surgery drops when you put it close to a radiation therapy facility at 100%. It's of course not 100%, but you take it as the norm. Then you see at 25 kilometers it already starts decreasing. At 100 kilometers it's only half. And at 250 kilometers it's only 1/6. And of those 1/6 of the patients, only 42% get radiation therapy. So there is indeed a problem. But this is the US. The US is like this, and Europe is completely different. This anyway is the Netherlands. In the Netherlands you have 21 radiation therapy departments, and the longest traveling times, only if you want to live together with the seals on an island, then you have a traveling time of exceeding 1.5 hours, because you have to take a boat to go to the mainland. But this is solved as well, because we increased over the last 10 years the number of facilities by 15, not new departments, satellites. So for example, Tilburg has a central place and 2 satellites in big cities to reduce traveling times. This is a possible solution. So this is not a reason, at least not in Europe, in large parts of Europe. Then what Professor Kuiten told, the changing concepts from maximal tolerable treatment to minimal effective treatment. It fits into this idea. This is completely correct. I completely agree with it. And we have guidelines as well. The Americans as Estro published guidelines to help us to select patients which might be treated with accelerated partial breast irradiation alone. And we have to realize, thank you for this picture, Abraham, that it is true life. It is done, even in the Netherlands, it is done outside of clinical trials, even if I'm not so happy with it. And we have people who strongly defend it, and many of you know, of course, Roberto Oreja, but Roberto Oreja is very experienced, and when we start doing partial breast irradiation, we need to have a high level of expertise, and this is not always available, and we know that there is a clear learning curve. Can we confront our patients, our first patients with this, with having a high risk of recurrences? And then we think, at least people say, that patients want it. Is this true, or is it rather marketing? The only company in Europe at this moment, Western Europe, who is aggressively approaching the radiation oncologist is one of those companies. They approach not only the radiation oncologists, they go directly to the surgeons and to the board of directors of the hospitals, and then they are putting pressure on the radiation oncologists to start using one of those machines for partial breast irradiation. This is not a proper way, and they base it on a publication, 5-year results, and if you read the publication, the median follow-up is 2 years and 5 months. What are we talking about? So what is really ongoing. The Ugly Truth, by the way, maybe you don't like American movies, but this is worth seeing. It's hilarious. What they did in the US was based on Medicare. It is a kind of general reimbursement system. They evaluated a lot of patients above 66 in between 2000 and 2007, and they looked for the use of partial breast irradiation with brachytherapy, that's with needles, versus whole breast irradiation, and then they looked to the rate of subsequent mastectomy, the risk of hospitalization or infection within the first 4 months, and the incidence of long-term toxicity. Now, should we go? No, the other doesn't want to. Doesn't think. Okay, let's go again. No, it's stuck. Okay, thank you. So they had the chance to look in the Medicare billing claims of more than 130,000 women. And they saw that the use of partial breast irradiation clearly increased from less than 1% to more than 13% in 7 years only. So it's becoming very popular. Patients who had partial breast irradiation were more node negative, less often chemotherapy, they were older, they were often the Caucasian type, and they had often more comorbidity. And what are the results at 5 years? There were more subsequent mastectomies, there were more acute complications, hospitalization, infection, more late complications, only less pneumonitis, but it's always below 1%. And all this is highly statistically significant. So you can see that in true life, in real life, partial breast irradiation, at least with this technique, is not as good as whole breast irradiation. Inferior effectiveness because of more subsequent mastectomies and more acute and late toxicity. And this was not the only publication, there is a second one from Presley, who exactly, based on another database, exactly had the same results. Now, what we should not forget is that we have a lot of techniques to give partial breast irradiation. External beam, peroperative with electrons, you can use special devices to put into the tumor cavity. There are a lot of possibilities, and each of those techniques is different. And they have some benefits and they have some drawbacks. For example, 3D conformal radiotherapy is, at least for radiation oncologists, the most convenient. It best fits to our current practice, but it treats a larger volume. The dose homogeneity is also best with 3D conformal radiotherapy, but it treats a larger volume, so you also include more of the other parts of the breast. For sparing the rest of the breast, of course, the target system with the 50 kV is best, but there you treat something like 1 to 4 cubic centimeters. It's a very small volume that you treat. If you look to the skin nose, most fit, but there are some bad reports with mammocyte. If you go to technical feasibility, I showed you the picture of Roberto Recchia, the expertise. You need quite a lot of expertise with some of the systems. And for widespread use, most available are external beam, of course, and maybe the mammocyte as well. And all of them, to remember it, they have drawbacks. So target volume delineation, I come back to that, is also quite different from one to another. Imagine you have a cavity, you took out a tumor, you put in a device and you irradiate. It's the cavity you're irradiating. The cavity is not necessarily your primary tumor bed. So it's difficult to compare the techniques. They have a different dose, they have a different biology, a different number of fractions, and BED stands for biologically equivalent dose. Dose homogeneity, overall treatment time, treated volume, huge differences, so I'm very much afraid that we have to wait for results from prospective trials. The only the only results we have with long-term follow-up is the Budapest trial, the Hungarian trial with quite good results, but only 88 patients. And the Elliot trial from Roberto Oreja with more than 5 years follow-up, with a clearly higher rate of local recurrences, up to 12.9% at 10 years extrapolated. So it has also to do with patient selection. And once we have the results, we cannot extrapolate the results from one technique to another. So I'm afraid that we are quite early in time to decide on which patients can start outside of a clinical trial of being offered accelerated partial breast irradiation. Now, what about long-term toxicity? There are always benefits and drawbacks, as I said earlier. Now, we have also the EBC-TCG again, and they have shown that patients who receive radiation therapy at long-term follow-up, in this case at 20 years, you have a slight excess of non-breast cancer-related deaths. And this is 2.2%, and most of this is due to circulatory disease. This is especially cardiac toxicity due to radiation therapy. And this is logical because the heart just lies behind the left breast, especially if you use conventional radiation therapy techniques. Like, for example, this, you see a patient, the heart laying very close to the thoracic wall. The tangential fields include part of the left ventricle and the left anterior descending coronary artery. Now, this delivers for sure a dose to an organ that should not be irradiated. And the results are that the higher the dose, less than 5 gray, 5 to 15 gray, 15 and more gray, the higher the risk of cardiac toxicity due to radiation therapy. So with a low dose, it's rather limited, even not significant, but the higher the dose, the higher the risk for cardiac toxicity due to radiation therapy. This, of course, is learned based on older trials, older techniques, and we clearly improved. These are the results of a dosimetric evaluation of patients treated in the 70s. The mean dose to the heart was 13 gray. In the 19s, it decreased to 4.7. In 2003, it decreased to 2.3. And now with modern techniques, we just presented it last week in Vienna, we are below 3 gray, even when we include the internal memory lymph nodes at the left side. And if we exclude the internal memory lymph nodes and we use appropriate techniques, most often it is in the range of below 0.5 gray. So, that's normally the time to take a nip of water, but I forgot that. The techniques, what about the techniques? Now, target volume delineation is very important, and in the past it was very easy. We had big machines and the target was very poorly defined. We could not miss it. Everything was big. Machines were big, target volumes were big. And then gradually in the 70s and the 80s we improved, we had simulators, and we started having an individual setup, simulator X-ray, and it improved. But it was, of course, not like we wanted today. Today we know that the target volume is small. In most cases is rather limited, and we have to define it. And we know that the target is moving. It's not a fixed target. The patient has a respiratory cycle. And we have much better machines. in modern radiation therapy, all treatments are prepared using a planning CT scan. You can see the CT scan as a very wide bore, a wide opening, because the patient has to fit through the machine in treatment position. Not like that, squeezed, but in treatment position. And every treatment planning is based on delineated target volumes and completely individualized treatment planning. And we have, I put a Vero just to take one of the most, let's say, special machines as an example. It's not a machine to be used for breast cancer, but we have very, very nice and even dedicated treatment machines nowadays. Now, target volume delineation, I can speak for a day about target volume delineation alone. We have a huge problem, and the problem is called variation. Now, we did a study, we published this in 2010, for the boost, which is similar to partial breast irradiation, on 8 patients, 13 observers, and all of them were experienced radiation oncologists. I was one of the participants. And we delineated the primary tumor bed and expanded it to clinical and planning target volume. And this is the result. It is very difficult to get to the same target, especially if you have a clip, it's easier. If you have a seroma, it's easier. But if you don't have clips or seroma, it's very difficult. And are we right here? Or are we right here? That's not true. I don't agree at all. We have to individualize based on everything we have available. That's why, for example, for all patients who get chemotherapy first, surgery, then chemotherapy, then radiation therapy, and if they need a boost, we invite them already early, before starting chemotherapy or during their first course, to already make a planning CT scan, because early you still can see the surgical effects. And after 4 to 6 months of chemotherapy, nothing can be seen anymore. And the clips are often poorly representing the true original site of the primary tumor. Now, to help in this, we started within Estro about 4 years ago with contouring exercises. We do it during the courses, during the conferences. We have online workshops. Recently, we had an online workshop very early in the morning so that people out of Australia and New Zealand could participate. So it's online, really online, works very well. And we are approaching to have a true international consensus. Not only Estro, also other groups active in the field, including the Americans. And this is just an overview of what we will present, a consensus of all parts of the complex set of target volumes for the breast, of course, the breast and the boost, partial breast irradiation, thoracic wall, and all the lymph node areas. Not the organs at risk, because they should be the same for also for esophageal cancer, for lung cancer, etc. And this is the team working on this. Then a little bit about techniques. A lot can be read in this book that we published 2 years ago now, with a group of people, and the breast chapter I did together with people from the MD Anderson. Now, very important, already shown by Abraham, I still want to emphasize that this should be standard in every department. Point. Respiratory movement control is not to reduce the motion of the patient. That is not the most important. The important issue is that you increase the distance between the heart and the breast or thoracic wall by inspiration. This is what you need to do. And then, this is with free respiration, this is with breath hold, you will irradiate much less of the heart while irradiating the breast. And this is easy. This is not expensive. There was a test, a prospective randomized trial in which patients were treated with inspiration breath hold with a very expensive technique and with a very easy technique, exactly identical. It costs, we do it routinely for all our patients, it costs 3 minutes more per patient per day, and all the rest is exactly the same. Then the techniques, this is very easy, I will be short in it. Forward planning, field in field should be standard to make the dose more homogeneous. That you have very homogeneous dose distribution. Why? Because it has been shown in a trial that if you give a homogeneous dose, you have much less cosmetic changes. You have less fibrosis because you will avoid hotspots, places where the dose in the breast is too high. If you then go the next step and you go to IMRT, you have an even more homogeneous dose distribution, especially if you have a complex set of target volumes, including the lymph nodes, but the drawback is that you irradiate to a lower dose a larger part of the body. So it has advantages, especially in complex cases, and we use it only in complex cases, otherwise not. But it has also some disadvantages. For example, in young patients, you will always irradiate part of the other breast if you use IMRT. So below 40, we never use it, because even a low dose to the other breast has at long term the risk of inducing secondary breast cancer. Concluding, how to start, all of us. Take care that the dose to the breast is homogeneous, and in nearly all patients this can just be done by field into field, not the full-blown inversed IMRT. To reduce the dose to the heart and the lungs, use respiratory control. And this is easy and cheap. The only thing you need to do is good instruction for the patient. About which patients need which treatments, we have to select patients. Just like for systemic therapy, you have risk factors. You have to define your target volume. You have to take care that the patient's positioning is every day the same. That's image-guided radiation therapy. This is all basic. This is all very essential. If you, for example, you have patients which might benefit from internal memory irradiation, I come back to that, and you make treatment planning and the dose to the heart is too high, 1 week of treatment. If this is successful, forget about accelerated post-breast irradiation, because what's then the benefit anymore? And we will, in the future, for some patients, need to combine radiation therapy with new molecular and other agents. So the new agents are there. And what comes as well, we are preparing a trial with preoperative radiation therapy combined with primary systemic therapy, and maybe that in the future we need less surgery after an intensive pre-surgical treatment. We used to do now first the surgery, then the systemic therapy, then the radiation therapy, and it can switch first chemotherapy, radiation therapy, and then surgery, and maybe in some patients we even do not need in the future any surgery anymore. So we have challenges, define your goals, target volume delineation is of utmost importance, weight, benefits and risk, use the techniques you have, and a lot is possible. Thank you very much to the people who contributed, and this is the department where I work. Thank you.
Thank you, Dr. Poortmans. Так как